I do, even though I'm a woman, and what I suggest all of you consider doing is that before you place your hand on somebody that might be perceived as uncomfortable, you ask permission. You know, I need to move you forward in your chair. I need to place my hands on your pelvis. Is that okay with you? Or on your hips? So if you ask permission, then it's out there on the table. They know that, and you tell them what you're doing, and you explain what you're doing. Usually, it's rarely ever an issue. But if it was a real issue and they just didn't feel comfortable with that, then the sheet method is an alternative that you don't have to be on the pelvis, that you could actually grab onto the sheet. Does that make sense? It's an excellent question, especially in this day and age of all the sexual abuse stuff going on. It's a great thing, especially for men, but also for women, but more so for men. You guys have to be careful about. So you want to make sure, but I always ask permission. May I place my hands here on you? So they know it's coming. And then they also are in control. Putting your patient in control and empowering them is a wonderful skill. If you can do that, it makes them feel like they have a choice. When they're in the hospital and they're not feeling well, or they're sick, or they've had a disability that they're dealing with, they feel like they've lost all control. So even little empowerments like asking permission of them to do something is huge in building their self-esteem and their confidence. Okay? So handle that. Let me think what else there was. The technique where I showed you using the leg to scoot. Where I showed you the technique of pushing them back. I didn't point out that what you want to do is you want to just plantar flex your foot to do it. You're not actually physically doing it with your body. It totally should be done all with your calves. Does that make sense? Did you all get a chance to experience that? So I noticed that was some people are having trouble with. You want to make sure you just plantar flexing your foot. So I'm using those big wide plantar flexors to do that versus my back. Make sure that your base of support as a therapist is usually, how did you phrase it? Staggered in the direction that you're moving. Does that make sense? If you're pulling somebody forward and you're this way, you're not going to be very stable here. You're probably better doing it from this position. And yes, we have to get low. You just got it. If your quads are burning when you're done with a transfer sometimes, then you've done it right. If your back is sore, you've done it wrong. Okay? When I first became a physical therapist and I started doing this, my quads were burning. Okay? It's a different thing than what I don't normally do, sustained low postures in my exercise routine. So it was really different for me. But that's what you'll feel it. You should feel it. And that's normal and that's okay. Makes sense? Any questions about what we went over? Anything that you saw that I should cover that I didn't, or Chris, that you saw, maybe a little tidbit that I should go over? No? Everyone's on target? Good. Good. Okay, so next we're going to go over just one transfer, and then I'm going to break out and let you practice. It's called the stand pivot transfer, as we talked about. And this, so the first thing you want to do with the stand pivot transfer is you just learn 3 options to scoot your patient forward. So we're going to scoot you forward. We're going to go ahead and do the other side. We're going to have you move your body forward to the edge of the chair. And then can you help bring your body forward? That is one thing I didn't stress when I demonstrated the technique is you want to encourage them to do as much as they can. So you ask them to, when you're bringing them forward with the pelvic slide, you want to ask them to bring their body forward as you're helping them. So you want to encourage them to try to activate their abdominals. Are any of our patients strong enough in their abdominals? I don't know that I've ever worked with any patient, at least in a rehab setting, that has strong enough abdominals. So we can always, any opportunity that we have to activate those abdominals is a score, okay, for that patient. Okay, so you're going to be here. So for the stand pivot transfer, what I'm going to do is come around the patient like this, and I always encourage, if my patients can, to help by pushing up. And I mentioned that before, so I'm going to have her put her arm here and try to push up. And what we're going to do is we're going to stand up, we're going to turn, and we're going to sit on the table. Now, you can, sometimes, we call it a stand pivot transfer. Sometimes patients will take a little step, and that's okay. Okay, so sometimes I think it should be more correctly called the stand step / pivot transfer. It's okay to take a little, if they need to take a little step. Some patients will not be able to take a step, however. If they're not able to take the step, if you have the foot on the side of the table, or by the place the direction that you're transferring to, the foot on that side, if it's slightly ahead of the other foot, it will be less likely to get caught, okay, and twisted on the other one. The other thing is if you're transferring with a wheelchair to or from a wheelchair, the front casters, you have to be aware that they don't get in your way as you go to turn. Right? So if they're pushed back, they won't get in your way. It does make the chair a little narrow, but at least you got them out of your way. Yeah. I didn't stress enough the position of the wheelchair and the surface that you're transferring to. You really want to make sure that this is positioned in the right direction. And I've got a little bit of a gap there, so I'm going to angle that a little bit more. Now, you don't want your angle too acute, like too much, because there's not enough room. This is a problem with cars sometimes. When we do car transfers, is the door doesn't open wide enough, so you have a narrow space. This is your door, so you don't want it so angled that you don't have enough space here, but you don't want it so far apart that there's room for the patient to fall. So that's why the position of the chair is real critical. Okay, so we've got your feet positioned. I'm going to come in. Now, the other thing is what to do with their legs. What if one of their legs wants to give out and I want to spot their legs? Some people spot their legs with both here. I feel very teetery when I do that because I've got a narrow base of support with my legs. I feel like I can fall either side pretty well, so I don't really feel well comfortable with that technique. What I like to do and what I would encourage you to do, there's a way, if you think about your shin, your lower leg, and you know this part here that's fleshier, if you put that against the patient's lower leg, so you want to do flesh to flesh, like that, okay? And you can block the knee. Can you see how I have her blocked there? So I'm going to go ahead and have you stand up. Go ahead. So while you're standing, I want you to let your right leg collapse. Go ahead. There you go. So I can just use my leg to kind of stop her leg from going. Does that make sense? And then what I would do is just go ahead and pivot her and have her reach back and have a seat. I usually encourage my patients to reach back if possible. Now this is where, if we go to have her stand up, if I don't move out of the way, you're going to get stuck, right? So I need to actually move with her as she comes up. See the difference? And when she goes to sit down, I actually move with her as she sits down. I know there are things I forgot or didn't point out. Anything you can think of?
Okay.
Corey, question?
How low do you want the bed? Because you don't want them to like flop down, and you don't want it to be too high that they get stuck.
You're going to get that sense depending on their height. You don't want it, you're right, you don't want it so low, that's exactly the answer. You don't want it so low that they flop. So you kind of have to judge by their height. So for, let's say, Phil was taller as opposed to the Tiffany, maybe they'd be different heights. So there's not a standard height that you would want it. You may not always have an option of positioning. Some of the mat tables don't change, or the bed won't go any lower, or the chair is a fixed height, so you don't always have the option.
Is it typical to find beds that go up and down in a lot of hospitals?
Mostly in the hospitals, they will go up and down. Occasionally they break, or they get stuck, or some of the older hospital beds don't go down super low because they have to keep them high to get the portable x-ray machines underneath them. So there's reasons why they were high for other reasons, other equipment not we aren't necessarily doing with this physical therapy, but for nursing procedures and things like that. So they didn't used to go low. Now some of the newer, almost all the newer beds have a much broader scope of up and down, but they don't. Not every hospital is fortunate enough to buy brand new beds in the last 2 or 3 years. So you will experience some hospital beds that don't go super low, and especially in your intensive care or your critical care areas. Good question. So let me just demonstrate and review it again. So if I'm going to block her leg, I'm going to use the fleshy part. It's easier if I'm going the other way. It's okay. If I'm going to block her leg, so let's say I'm going to the right leg again. Okay, use the leg. So I'm going to come in, block her like that, and now come over. Oops. Oh, I forgot to move her foot, didn't I? See what happened? We got kind of tangled there. So go ahead and sit down. It's tricky. Sometimes you have to figure out where your feet go, and that's okay. Take the time to do that so that you don't angle. You're going to lean forward. And then, reach back. And sit down. Make sense?
It's okay for them to do a little shuffle.
Yes, it's okay for them to step. I actually like them if they can to step. It's a preparation for weight shift and stepping and that sort of stuff. For walking, preparation for walking. Now, scoot to the edge. If she wasn't able to, if she really couldn't help me, and that was hard, I will actually kind of align the feet where I almost headed that direction. Does that make sense? If I'm concerned about twisting, you don't want to twist the knee and you don't want to cause some problems. I will, again, there's that planning as to where you're going to end up and where you want their feet to be. So I may actually start, if they really need a lot of help, I may actually start in there and then come in like this and then just up, well, we get her all the way up, sorry, stand there. Stand there all the way up and then down like that. That makes sense?
How do you know which leg to block?
That's a good question. If they have one that you know is weaker, then that would be the choice that you would choose. So if they've had a stroke and they have hemiplegia, then that's typically the one that you block. Sometimes you don't even know that you need to block. You're just going to be, a lot of times I don't know if they're getting up and they're in for pneumonia and they're just weak and there's no reason for you to believe that they're going to collapse in their legs, but if they do, I'm just close and I'm ready so that, go ahead and stand up. If she does collapse, I can just kind of put my leg there to stop it. But I may not always block. That's just if you feel like you need to. So you kind of should have a sense before you get them out of bed, knowing who your patient is and what their deficit is as to when you get ready to block, and if you don't need to, you can always back off.
So what verbal instructions would you use to encourage the patient to participate? What are some key words you can use?
Squeeze your butt.
Squeeze your butt.
I mean, it's not like that, but
Let's rewind. Say again. I know you meant something.
So I mean, use their leg muscles. To
Good.
say
Okay, so you can say squeeze your leg muscles, push with your leg muscles, something like that. Use your legs, something like that. And sometimes, Tiffany was very obedient. Some patients sort of just know what to do, but if you have trouble, you're going to need to use your verbal instructions. So when I count to 3, push with your legs.